Hello, everyone. Welcome to another episode of the Nephro-Logic podcast. I'm Neghae Mawla, an interventional nephrologist out of Dallas.
I'm Monnie Wasse. I'm an interventional nephrologist in Chicago.
And we have a guest today. Please introduce yourself, Stephen.
Well, hey, guys, thanks for having me. Stephen Hohmann, vascular surgeon from Dallas, Texas. I've watched your first couple episodes and excited to be the first surgeon on.
We're excited to have you. You know, you are a perfect person to have on here. We have shared a lot of time together. You've come to my center. I've come to the hospital and watched you do cases. Of course, you and I have gone to Chicago and done her access sessions there. So you were the natural choice to have today.
Well, thank you. That means a ton to me, and I love this topic, and I love that you guys are doing it. So excited to be here.
Really delighted that you're joining us. So our last conversation was around what we wanted a surgeon to know about some of the challenges that we face or see as the maintainers of a dialysis access for a patient. Mostly the value of having you here is because you're an experienced surgeon who does a lot of dialysis access. You've seen some of the wrinkles. You've seen some of the things that have worked really well. I'm interested in your point of view about some of the things that we brought up on our previous podcast. And I'll just start us off. One of the things I've heard you talk about a lot that is one of my pet peeves is tunneling. And I'm curious as to, what your view is of what the training is like for junior vascular faculty and how this sometimes can go wrong and what we can do to actually make it go right.
Thank you for the shout out, Monnie. You guys are totally right. I mean, I love to say that you were wrong because it'd make for a great controversial debate, but in most part, I'd say you're right. The one thing is tunneling is one of the harder things to teach. It seems easy, but it's something that's really difficult to do because most things you can kind of show somebody how to do or kind of actually directly direct them, but tunneling is kind of more of a feel. And clearly people do a couple things wrong. One is depth, right? And you guys mentioned that. So how deep is too deep? I definitely think you should at least see some deformation of the graft under the skin. You shouldn't look at an arm and not be able to see any of the tubing of the graft. And as we kind of talk about that graft, kind of which type you pick, I don't think really matters so much. As you mentioned correctly, Monnie, 4 to 7, straight 6, 4 to 6, they've all have the same outcomes as far as steel is concerned. So I always say it's just kind of like whatever brand you like. When you really look at all the data, they all have essentially the same thing, but it's getting that tunneling right. I think sometimes people choose too small of a tunneler head. I think that's one of the things. So the tunnelers that we have come in different head sizes. And so you can do it with a 10, an 8, a 7, or a 6. And sometimes if you make the tunnel too small, it's very difficult to pull the graft through and it can be a little too tight. So that's one of the things that I teach is to use the larger head. And the other one is it's also very patient dependent. You have a younger man, really thick dermis versus kind of maybe an elderly woman, very thin dermis. So it's really difficult, but just like most things, and I think you brought this up, it's the thought behind it. So as you're tunneling, you want to think to yourself, is this correct depth? Rather than a smooth kind of passage, it tends to be kind of more of a jerky maneuver. For whatever reason, seems to do a better job of kind of clearing off that dermis. Also, after you pass the tunneler through, before you pull the graft through, is feeling how well can you feel the metal tunneler underneath the skin is a couple of things that I recommend to people. The other point that you brought up, which is very apt, is the location of the graft. So it's not just the depth, but where it is on the arm. I usually say thumbs up, but you said a handshake, and I think a handshake is probably a better description. But making sure that if somebody sits there, that their graft is in an easily accessible portion of their arm. The only exception to the rule that I've found is home hemo people. They like it a little bit more on the inside of their arm. So if they're sticking themselves, as that becomes a more common thing, you actually want that more medial than lateral. But people in general tunnel it too deep and they tunnel it too laterally. So those are a couple of things that I really stress, but I loved your guys' points on those. And once again, one of the more difficult things to do, and certain parts of the country, you don't put in a lot of grafts. So if you're not used to putting them in, tunneling it for the first time can take a little bit of practice.
The home hemo thought, I hadn't considered that actually. So that's a good point. Thank you.
Yeah, that's a really good.
And it came from your other point that you said about you got to go visit a center. Everything I've learned about where to put a graft was from the dialysis nurses because I went and you assume that you've done it right because Dr. X taught you that and somebody else taught him and you assume that's the correct way. But the dialysis techs were like, why don't you put it farther out on the arm? Everybody always has to rotate their arm in order to access. And I was like, well, I mean, I don't know, but there is no reason. And then also one time I tunneled it very lateral on a patient. She's like, yeah, I love where you put it, but I do my own access and I have to look in a mirror to stick myself. That was just something to keep in mind. I do also like Dr. Mawla's mention of, I do like to be able to hold the graft. You should be able to have some sort of tension on the graft. If there's too much skin movement on top, you worry about the tech's ability to kind of secure the needle in position also. So There's a lot of subtleties to it, which whenever something is more subtle, it makes it more difficult to pass that knowledge on to somebody else.
So thanks for commenting on that previous podcast. I'm glad you're in agreement with a lot of those points. One of the things that we do commonly that is very much in line with the placement of a graft is, tunneling a tunneled catheter. And you're not going to go too deep. It's the same principle. You want it to be very superficial. You're absolutely right. When you're using the tunneler, you're getting a little stutter as you're pushing it through, but the
Sure.
principle is not to make it too deep. So for the surgeons that are listening to this pod, are there good models to practice on? I mean, it's really a lot like a chicken breast, right? Or there are good models that are used that vascular surgeons could be able to practice this on if they don't insert a lot of AV grafts at their centers?
That's interesting. I don't really know of any. The animal models tend to have too thick of dermis. Most animals have a much thicker dermis than we have. And then the chicken's just not long enough as far as kind of skin-wise. But it does have that kind of sort of sensation. I think it's like anything else. Whenever you first kind of embark on something or trying to perfect something, and every time I do it, I'm thinking, how can I do this better? But it's just to take your time. And there's certain parts of the case where I always say, okay, this is kind of a slowdown point, or hey, this is what we're doing. And the way I do it is I usually just then start to explain to everybody else what I'm doing. That's my own method of slowing myself down. It's like, okay, we're going to tunnel it this way because of this. And the Hawthorne effect, the more you pay attention to it, the better you get at it. And as you're tunneling, as you're passing the tunneler, thinking to yourself, okay, is that a good spot or not?
So you heard our very passionate plea
Sure. Yeah.
around creating a new arterial anastomosis if there is an interposition graft. I'm curious as to what your point of view is and what your approach is. You want to keep the axis in the same location. The patient has a usable fistula. Maybe it's highly aneurysmal, or maybe for whatever reason, the skin has lost its integrity and you want to put something new there. What's your approach to the patient in that regard? And are you somebody who is on our bad list of tying it to a long stump? I hope you're not, but maybe you are.
No. I wouldn't be friends with you if I was. Well, I learned it from you, or I heard people talk about it. I never thought much about it until I had one. I went to go declot where I had hooked it in that way. And it was open surgically. It was extremely painful. I'm like, why did I do this? And so ever since then, I've been a prophet of the fact of to create a new arterial anastomosis. You can hook it into wherever you want venous wise, but I think what's underappreciated is the arterial anastomosis. And I find that to be one of the Achilles heels of declots. Even if I do it open surgically, I've done a couple things different. One is I never attach a graft to a stump of a fistula. Just create a new access site, and I don't attach it to somebody else's old graft. You should be able to find somewhere along the brachial artery where you can make a new anastomosis. The other one is if I'm going to do an upper arm loop graft, I like to make the arterial the inner portion. So if it's a left arm, then it rotates kind of counterclockwise, and if it's a right arm, then it rotates clockwise. I like the inner arm as the arterial because I find it an easier angle. I feel you can almost do whatever you want to the venous side. And of course, if something happens, it's the venous side, you can fix it or abandon it. But the arterial side, I think if you come at and you spoke of angles, I think if you come over the bicep, that's a very difficult area to declot, percutaneously open, whatever. And you end up in these weird situations where you're really pulling on the artery. I think that's where you can get embolization. I think that's where you can get disruption of the anastomosis. So I try to avoid the arterial anastomosis coming over the bicep if I can at such a sharp angle.
That's a really important point. I don't think that a lot of people consider that. They just kind of put it in like, where's the angle looking right and so on, rather than the whole principle. When I was at one of my previous institutions, there's this whole principle of the arterial anastomosis is on the side of the pinky. So it was pinky pull. And that bet is all off where I live now in Chicago, where the venous and the arterial anastomosis can be in whatever location they find that's sufficient. And so that's a really helpful point of view.
So interesting, because same here. I see it on both sides. I see pinky pull, thumb pull in a loop. I don't think it matters. In terms of when I do the declot percutaneously, I find that if the venous anastomosis is actually medial on the inside of the arm, opposite to your configuration, Stephen, the venous outflow is more kind of in line with the vessel. Like we talked about, and Monnie talked about the angle that she likes the venous anastomosis. And the arterial anastomosis tends to be more the T-bone 90 degree. And I find that to be easier to declot than in the reverse configuration, because there my surgeons are not always mindful of the angle of the venous anastomosis if you're coming on the lateral side.
Yeah, and I guess that speaks to another thing that we can jump into, which is the kind of anastomosis and the angle, and then that also plays into the lengths of the graft. You guys were talking about how long of a graft you need. One of the problems when you do an upper arm loop or if you do a thigh loop is you run out of distance quickly, especially if somebody has a larger arm, so you burn up 5 centimeters getting down to your artery or vein, especially if you're trying to make a gentle curve around the bicep. Most grafts come in 45 lengths. There are a couple that come in 50, and so I pull a 50 length one if I'm doing an upper arm graft on somebody with a larger arm, and that buys you more length. I like to use the entire graft on everybody. Unless somebody's very short, you can almost use the entire graft length on everybody, and my thought is then it gives you plenty of room to access, to revise. When I tunnel around that medial side, I like to leave a large amount on top of the bicep, because if you stick through it, you just hit bicep. Unlike you mentioned, if you stick through it, then you hit median nerve or brachial artery or all sorts of stuff that create trouble. The anastomosis sounds like an easy thing to set up, but it tends to be sometimes difficult just because as you come over the bicep, you then sometimes almost have to kind of go under it, and kind of configuring that with the person on the table versus when they stand up or move their arm. Sometimes the anastomosis, it sounds like you could always get it at that nice kind of subtle angle, but sometimes you just almost have to bring it in at less of a smooth angle as you'd want, that more 45 degrees that we talked about instead of somewhere between 45 and 90. Obviously, you don't want the T-bone, but it's sometimes hard to get it to lay down. I think one of the other things for surgeons to keep in mind is trimming the graft. So is to trim the graft without any retractor in place. So I like to trim the graft without the retractor in place, because a lot of times when you have the retractor in, it kind of pulls everything apart and you think it's nice, and then as soon as you let it go, it's either too much or too little. So because of course the arm is going to live without your retractor in place after you create the anastomosis. So those are a couple of things I like to do, but I think it boils down to just like anything else. You just want someone to be thoughtful about it, and there's a lot of different ways of doing things that have great outcomes, but they almost all involve thought. I do it because of this specific reason. And then it's bouncing off of you guys. I heard from you guys at first years and years ago what a pain in the rear it is to declot that stump of a fistula, until I had to struggle with it myself. And I thought, why am I doing this to people?
I have two things I want to ask you about.
Sure. Yeah.
Your previous comments. One is we have done a subsequent segment on blood pressure. So you mentioned that you'd like to use the full length of the graft. Would cause you, outside of the length of the arm and the size of the patient, does blood pressure ever play a role in your decision to keep the graft standard length, or do you ever trim it down because a patient tends to be more hypotensive?
Yeah, it's an interesting question. I don't ever trim it down to worry about hypotension. I just can't ever predict who's going to be hypotensive. I mean, length is to just the first power, radius is to the fourth power. I don't know how much really that adds to the conduction system, adding some length to it, minus maybe a hero graft or something like that, where you're adding double the length with the venous outflow component. I just don't think it makes that much of a difference. And I hate mini loops. They just annoy me. I have switched over time. I do very few straight grafts anymore. I think number one, it's a shorter length. Number two, it just increases your risk of steel. And if you're going to go ahead and get out a vein higher up in order to do the venous anastomosis, the artery is right there. The one thing that I do see that I think is very important that is not spoken about among surgeons, but is when you do that dissection, you have to free up more artery than you think to get the median nerve away from the graft. I've had a lot of patients return to me for steel when it's really median nerve dysfunction, where, they complain of thumb, index, middle finger bothering them, and everybody says it's steel, but no, it's not really. It's median nerve, and the median nerve can live in a variety of spots in the upper extremity, but tends to live in more kind of proximity to the artery. You want to get that away from it, because I've taken people back where you can see the PTFE is almost kind of stuck to it or fused to it, that I think is what causes some of the median nerve dysfunction.
That's a great and important point. I think the other question that I have for you is, what type of graft do you like to use? We talked a little bit about grafts for specific reasons, such as in the hypotensive patient and in patients that may be prone to infection. Do you have a preference? Is there a reason you have a preference? Could you comment on that?
I like PTFE. I'm not as much of a biologic person, just because I really like to make a loop, and I find that the biologics more difficult to make the loops for, and they're also harder to declot surgically because you can actually cut through them as you're trying to dissect them free versus the PTFE you can't. I do like integrated ring PTFE, so I like to have it with some strength on it, so in case a patient falls asleep on it. And I do like some of the thicker wrapped grafts as far as when I'm wanting to use it for an early access. I tend to use those, kind of the triple wrapped instead of some of the other ones with the kind of elastomeric membrane. So I tend to like that graft as far as being thicker, and they've also kind of made it kind of tapered at the end, so it's a little bit easier to sew. They also make that one at 50 length. That's the other reason why I tend to pull that one. I tend to like 4 to 7 just because it's easier to sew a 4 to a 4 artery than a 6 to a 4 artery, but for no other reason. Although I never thought about, once again, talking to each other. I never thought about Dr. Mawla's point as far as you have to get out a different balloon if you want to blow in the arterial side. I never thought about that, but that's actually a valid point.
I mean, it's a nuisance complaint. It's not really a valid complaint, I don't think. It's just, but
No, I mean it's a thought, and what I've never really understood is why sometimes you see that stenosis at the arterial side, that PTFE. I don't understand what that is. Whether that's just external forces pushing on it, because theoretically there really shouldn't be much there. But you definitely will see sometimes the stenosis at that tapered end of the arterial anastomosis.
I also think that a lot of people will treat it because they don't realize that it's a tapered graft.
yes.
Yeah.
Honestly,
Yeah.
if you don't go back to the operating note, and not everybody can because they may be in a different hospital system or EMR or whatever, but that's something that I always check because I'm like, I don't want to inadvertently think that that's either a banding that happened or it's a taper that looks a little weird. And I don't want to take a bigger balloon to it. So, and then all of a sudden have the patient have steel.
Thoughts on the immediate use grafts? How soon do you use it? Do you like it? Do you not? It tends to come in and out of favor within the community, both on the nephrology side and on the surgeon side. So where do they stand right now?
I'm pretty much only using them on my heroes where I'm removing a catheter and I want them to use it right away. And I just tell the person that you're gonna have it out. I do 17 gauge needles for a week is what I do. It seems like it works fine. I think you could do it more often. It's just if somebody already has a catheter, it's just kind of a hard sell. And grafts, I just wait 2 weeks. I don't think there's reason to wait any longer. It's a little hard sell to put an early access graft in somebody that's never had one because they're like, well, my other one we waited and the arm is swollen and it's inflamed. And so I would say it's just an occasional use.
So that's an interesting pattern. Where I am, the surgeons generally will use an early cannulation graft just right off the bat in an incident patient. Is there a reason that you have a preference like that? You just think they hold up better with a standard PTFE? Do you feel as though, giving it a little bit of time to incorporate is going to be beneficial? What are your thoughts around that decision?
It's usually just patient comfort. And a lot of times now it seems like I'm having less crash start patients in a nice way, or they're already coming to me and they have a tunnel dialysis catheter, or the nephrologists have gotten very, I don't know if aggressive is the right word, but I would say adept at like, maybe they have a Quinton, dialyze them 2-3 times, put in a graft, let them heal for a week or two. They don't need dialysis for a week or two, and then go ahead and start them on the graft. And then that way the patient's happier. They get in an outpatient center. They're not getting started in the hospital, infection risks and all that stuff. Seems like you guys have gotten better at, I don't want to say putting people off, but like managing that very last moment. Because I say to my nephrologist, if you give me a week or two, you can use it. And like somehow they can always find a week or two with medications. I mean, minus certain people, ICU and that sort of thing. But almost everybody else in outpatient, you can get them almost there and get it started.
Most patients become strangely adherent that last few weeks because they don't want to start dialysis.
Yeah.
So suddenly their volume status is okay. They're watching their diet and so on. So you can get by. You're absolutely right, though. You can generally get them by for 2 weeks.
I would rather someone have their graft accessed in an outpatient center than in the hospital. And I'd rather those just, nosocomial infections. I think that's actually good for the world to try to get people kind of
Agreed.
started as an outpatient. But I'm getting a lot more earlier people. I'm getting a lot more CKD5s. I'm getting a lot more PD referrals. I'm getting a lot more people that want to do home hemo. So I think there's a lot of positivities coming through. There definitely seems to be some change in the nephrology world that I'm feeling as a surgeon in a very nice way.
I think the nephrologists are becoming much more in tune to access placement timing as opposed to waiting to the very end. Now, one of the things you mentioned was using your standard PTFE at 2 weeks, the old mentality of waiting 4 weeks, 6 weeks, at least
It's not
here.
necessary.
And I don't think most of the surgeons here in Dallas use it. Monnie, again, we've discovered there's a lot of geographical variations. What's your timing for your standard PTFE usage there?
I think the majority of people who put in a lot of grafts, PTFE grafts, will say 2 weeks. I think a lot of those individuals that don't put in very many grafts generally say 4.
Yeah, and whenever I talk to our residents or fellows, I always ask them, what are we waiting for? And most people say we're waiting for the anastomosis to heal. And I say, well, do we wait on a FemPop bypass graft 2 weeks to open up flow? Well, no, we use, open it up right away. So it's not that, it's that PTFE actually has holes in it. So PTFE has like 60 micrometer holes. If you look at it under electron microscope, it's like this. Red blood cells can't escape through, but it's the body actually grows into it. So the body, that's what you're waiting for, is incorporation of the body into the graft. And that takes 2 weeks or so in almost everybody. You could argue maybe somebody's a little bit of a slow healer, but even at 2 weeks, you should have some sort of tunnel formed that when you take out the needle, it doesn't bleed.
Okay. So, and most of the immediate use grafts that I've encountered, soft tissue swelling, those kinds of things, usually take 5-7 days. And so I've found that a lot of my immediate use patients, I can't actually use it day after necessarily. I usually end up waiting one treatment, sometimes two treatments before I can use it. So that kind of closes the gap in terms of, do I really need to use the immediate use PTFE? The dialysis centers complain about it. They think it's harder to stick sometimes because it's thicker in that extra PTFE layer. Again, just kind of local considerations to maybe pros and cons for immediate use versus a standard. If we're waiting 5 days versus 14 days, I don't know that there's that advantage anymore to the immediate use graft.
I have a little different experience. The nurses in where I am don't care if it's standard PTFE or early cannulation. The protocol for cannulation is very similar. We go very conservatively, start with 17s for a while, and then advance. The only difference with the early cannulation grafts is just that you need to hold pressure for longer when you take the needles out. At least that's what the advice is for some of the early cannulation grafts. But otherwise, all bets are off around how they do, how they perform. I think that they're all relatively similar. Stephen, I have one question for you. So you mentioned the anastomosis and that your trainees are sort of strangely waiting for the anastomosis to heal. If your graft goes down within the first month, do you take the graft back and fix it, or do you send it out to the interventionalists?
No, I take it back myself. When something goes down that fast, you have to really wonder about technical error. And the problem is that it sounds bad to a surgeon to say you have a technical error, right? Because nobody wants their thing to have a technical error, but you have to be honest with yourself that things can happen. Grafts can get pinched or kinked or twisted or something. I really think you should take them back, because I think it's unfair to an interventionalist that if you pull something across the arterial anastomosis and have a blowout, then that's just a disaster. And if it's that early, you have to take it back yourself. And I do like to do declots myself, and I've had plenty done by Dr. Mawla and the other people in the area. But if you don't ever take anybody back for yourself, you don't understand some of those struggles of what people are trying to do, or like, why do you switch my anastomosis here? So I think as a surgeon, it's good to occasionally do some of them to understand the challenge of it, because I think you said this also, Monnie, which is that every time I put an access in, I'm planning for the declot or the revision every single time. The first two things I tell every patient before I meet them is, number one, nobody wants to be on dialysis, and I understand that. Number two, there's no perfect dialysis access. So they're all abnormal, and we have to plan for it. I will tell you the one stunning fact that all the residents and fellows can't believe is that the primary patency of an AB graft at 1 year is like 20%.
And we love it, right? We're
It's
ecstatic about it.
unbelievable. It's unbelievable to them that, only 1 in 5 grafts doesn't need to be touched within a year to remain patent.
Yeah,
I mean, it's insane.
It's completely different from all of the other literature with use of PTFE in any other location. You're absolutely right. So I asked the question about whether you take it back because that's helpful. One, it informs you about what problems exist and so on. But there are surgeons in the community that don't do that. They refer a patient to an interventionalist within the first week or two. And my policy is I don't take your fresh graft within the first 4 weeks because I don't want to blow out the arterial anastomosis. That's what makes me nervous. I'm glad to hear you reinforce that concept.
I'll do it though. A lot of it has become dialogue with you and the other surgeons in the community. And I'll say, look, I will gingerly come across the arterial anastomosis. If you're within 4 weeks and you're down, you may get a covered stent across the venous anastomosis. So if you do not want me to stent the venous anastomosis, you better take it back yourself.
Yeah, it bothers me if something goes down that fast. It just has to be something you're missing. You know what I mean? The natural curiosity of medicine should make you say, Now, 6 months and you see a tight, oh my God, here's early intimal hyperplasia. That's just the way it goes. But like a week or two, something is wrong.
Yeah, that's cloaked under the technical failure. I think we all have our different kind of practices. Neghae, it's good to know that you're the guy who accepts those back. You probably are very cautious about the balloon size, I imagine.
I am a little more conservative. And at the arterial side, if I struggle or I feel like I can't do it, then I, say, okay, we need to get you back. I'll definitely give it a try, especially if it's in 2 weeks. It's always with a phone call with the surgeon saying, hey, this guy's clotted. You want me to do it? More often than that, actually, the surgeon is calling me saying, hey, this guy's 2 weeks out clotted. Will you do it for me?
So, Stephen, I have one last question for you because I think as we wrap this up, what makes for an optimal partnership between the interventionalist that you tend to use and you? What makes for a good matchup between the interventionalist and the surgeon in their community or at their institution?
I mean, number one is open communication. And I'm a big fan, especially in the era of everybody now epic chats or sends messages or does other things. I always stress to everybody, just pick up the phone. In 30 seconds, you can convey way more than you could ever convey by sending a message or doing something. I always have all my people on speed dial, and I call them with the patient in front of me and say, I always say the patient's in front of me, but hey, I'm sitting here with Mrs. X. I know you declotted her the other day and you wanted me to do something. Just want to be clear, you want me to do this. Yes. Yes. Okay, great. We'll take it and do it. And vice versa. I've worked on this guy before. Feel free to stent over the anastomosis. I'm not going to go back there. So if you think you need to, go for it. I think it's that really number one, open communication. And then I'm setting similar expectations for the patients with each other, saying these all have problems. And it's not uncommon to have to go back 1.4 to 1.6 times per year to have something done. It's not a failure, it's a maintenance. And so I can do your maintenance. Sometimes Dr. Mawla's going to do your maintenance. You take to this mechanic for this. Sometimes there's certain things I have that he doesn't, but he can get you in a lot faster and do some things that I can't. And so I think it's understanding each other's limitations and restrictions, but then also you may have to wait on Dr. Hohmann because he's very busy, but I want him to do this for you specifically. Or I'm going to send you up to Dr. Mawla. You may have not met him before, but he's got my seal of approval. So I think it's being honest with the patients and then also saying the disease process is bigger than us. We're fighting something the body doesn't want. And I think it's setting those similar expectations amongst us. I think that really makes for better care for the patients and they better understand their disease.
Great
Okay,
points.
thank you. I have one last question for you, Stephen, before we close. For a perm cath, what is your suture of choice to secure it down?
So, yeah, he says this because I'm on this mission. I'm on a crusade. I'm a crusader of sorts. And I see all these people with these two like bite marks on their chest. It's like the vampires have gotten them from permanent sutures. So I use a 3.0 monocryl on an SH needle. The SH needle is a non-cutting needle, so it doesn't make as big of a hole in the skin. A cutting needle is kind of shaped like a triangle. A non-cutting is really a round one. You can secure it in. It goes away in about 3 weeks and it doesn't leave a mark. And so I'm a big proponent of putting absorbable sutures onto tunnel dialysis catheters because as with the PTFE, the body actually grows into the cuff and that's what holds it in place. And we've all struggled to get them out. If they just slide out, in my opinion, they're probably infected. So using non-permanent sutures, I think is wonderful and I love it. Thank you for bringing that up. That's near and dear to my heart.
Stephen, thank you for joining us today. I think this was very insightful. A lot of good tips for nephrologists and interventionalists, a lot of good tips for surgeons.
Yeah. Well, thanks for having me. I love it. I love your stuff. Monnie has a phenomenal meeting up in Chicago where all of us could learn from that. That's actually how you get people to work together. So thanks for having me up there as well.
You're welcome. We'll bring you back another time when we come up with something a little more controversial for a surgeon. But I'm hoping we get some surgical engagement around this, and we'll definitely bring you back for further discussion. So thanks for joining today.
Yep. Thank you.
Wonderful. Thanks for having me.
Okay. Bye.
Bye-bye. Have a good one.